Hey everybody, this presentation is just going to highlight and go over all of the practicum requirements and all those fine intricacies of the practicum. So as an overview, some terminology you need to know. Practicum is just that educational experience outside of class. You come to class for all the didactic work and then you go to practicum. So the term clinical means just in the hospital. That is your clinical setting at the hospital, whether that be the ED, the ICU, labor and delivery, whatever need be, that's the hospital setting. And field is considered just strictly that EMS ride time. The institution carries a $1 million liability insurance policy. That is what is required from our clinical sites for essentially medical malpractice to allow students to be able to go to any practicum setting. Most generally, that is a requirement from hospitals more specifically than EMS. So if you are injured in the practicum setting, that is your responsibility. That does not fall under that liability insurance, nor would it fall under any kind of workers' compensation. So that's why we always ask and suggest and promote that you carry your own private insurance. For clinicals, you schedule all of those in FISDAP or with the clinical coordinator, just whatever process is set up by the hospital at that time. Most generally always, it's going to be scheduling for that clinical site within FISDAP by a set schedule from that clinical site. You have up until 72 hours before that shift to be able to schedule for it. So you can schedule for that shift a month in advance. But if you schedule in advance, you can only drop that shift within 72 hours prior to that shift. If something's come up in your life or whatnot, or you've picked up an overtime shift at work, whatever it may be, you've got up until 3 days before that shift to be able to drop it. And this is all stuff that's been requested from the clinical sites, so we need to adhere to their policies. Each department at the hospital, or whichever clinical site may be, each single department has to have a clinical agreement. It's not just a WVU hospital's clinical agreement. It must be for the emergency department, the ICU, the OR, whatever that single department is. Also, you will be precepted by an RN or higher. So make sure you're not just tagging along with a CNA or something. It must be an RN or higher, such as a RN, a PA, nurse practitioner, whatever it may be. Prior to a field shift, whatever you've scheduled with your preceptor, you need to put that into FISDAP at least 24 hours before the shift. Within FISDAP, you have the ability to manually add your own field shifts. So be sure you're putting in there the respective day you're going to go, all the appropriate times, everything. Again, 24 hours before that shift. Same thing in the clinical side. Those field agencies must have agreements in place with the institution to legally allow you to perform skills and to do time at that agency. Also, you will be precepted by an approved paramedic preceptor, which will be addressed later in this presentation. All paramedic preceptors must be approved by the clinical coordinator and that respective agency for each role that they will fulfill. So some agencies, even though you may have preceptors who want to take students, that agency may not allow them, or the institution itself may not allow them. So again, those must be approved by their respective agency and the clinical coordinator. So there's two levels of preceptors. There is the evaluating preceptor. That preceptor must have one continual year as a paramedic, not just 1 year in EMS, 1 year as a paramedic. They can do all the phases, so basically, spring, summer, semester, everything except the last portion of your paramedic program, which is called the capstone. That evaluating preceptor can do all of those parts. Then there's the internship preceptor. These are basically classified as the better preceptors. Those are ones who have at least 2 continual years as a paramedic or have 750 ALS calls. That internship preceptor can precept you at any point in time. Now, a big thing, None of your preceptors can be immediate family in some type of relationship with the student anyway that's going to create a bias. So no boyfriends, no girlfriends, no wives, no husbands, no cousins, nothing in close relation. Now, if it's a, 19th cousin that you just happen to randomly find out that you're related, that's fine. No immediate family. As a student, you should arrive to your shift just as you would with your regular shift work. Arrive promptly. Dress appropriately, ready to go. So as soon as you walk into that building, that facility, you're ready to go. That would include your student polo, appropriate pants, and foot attire with your student identification. Now with foot attire, if you're going to the hospital in the clinical setting, wearing a solid collar tennis shoe would suffice. You're not required to wear the typical type of EMS boots in the emergency department where you'll be on your feet, 12 hours a day. So some comfortable foot attire, but appropriate. Don't wear your Crocs or your flip-flops. Maintain good personal hygiene, please. Just look good, smell good whenever you go. Some fresh deodorant, a fresh shower, smell good when you get to the site. Perform all assessments and skills under direct supervision of a preceptor. There is no freelancing in the practicum setting. And be an advocate of the patient. Use it as a complete learning experience. Assessments are key. You'll get plenty of time to do IVs and other skills, but seeing these patient contacts and getting good understanding of their diseases and disorders is what will make a huge difference. This is an example of appropriate student uniforms. Wearing your polo, tucked in, dark color pants, EMS style, whether you wear the tactical style with all the pockets or whatnot, boots, student ID tag, and again, if it's in a clinical setting, a dark colored tennis shoe would suffice. Basically the same type of shoes that the nurses are going to be wearing. Overall practicum requirements for hours. So you can see everything is broken down here by term. So in the spring, that's heavily focused on just ER time and field time. There will be some medical command assignments built into the spring, so all that's essentially virtually, so you don't have to go to medical command centers. Summer, big focus is on ED and in the field again, as well as labor and delivery, getting into pediatrics. Then in the fall is when everything kind of else starts to come in for more intensive care, respiratory, and then field internship. That is the capstone portion. Now the hours that you will see listed for field evaluation and field internship, that's what those little asterisks mean by the total. That is not a minimum amount of hours. That is on average of what you're going to spend. So the big thing is what will be coming up is the patient counts that you will need in the field setting. This goes over all the minimums you will need for patient complaints and impressions that you'll see based on whatever their complaint or depression is, whichever you log into FISDAP, and also goes down by the age groups of how many pediatrics you need, of geriatrics, as well as their age groups, and then by classification, whether that's trauma, medical, or obstetrics. Then also highlighted at the bottom is the skills and interventions needed of 50 medication administrations, and that's medication given through an IV or an IO. 2 inhaled meds, so 2 nebulizers, 2 IM injections, 50 IVs or IOs total, 10 ventilations, and 5 live intubations. In the field setting, what classifies as an ALS call, so you can see in that bottom box there, in the springtime you need 10 total calls, 5 of those can be ALS, then after spring everything must be an ALS call. So that ALS call is an emergency response where you have assessed and interviewed the patient and the patient got a successful IV and an EKG, or a medication and an EKG, or IV and medication. Okay, so that first bullet, if they were just given an IV and put on the monitor, that's ALS. If they were given a medication and put on the EKG, like they were given IM glucagon and put on the monitor, that counts. Or if they were successful IV and a medication, such as giving that patient an IV and giving Narcan, that counts. Also, that patient is not required to be transported. You just have to do paramedic things on a call. Oxygen and oral dissolving Zofran do not count as ALS medications. Also, do not count or log interventions that the EMS crew did not perform. This would be an example from interfacility transports, to where you've gotten the patient, they already have an IV established, medications are already started on a pump. You cannot log or count those things if your crew did not do them. However, if you're doing those interfacilities and that patient requires interventions such as sedation pushes or whatever it may be, you can count those. So again, in the spring, 10 total calls, 5 ALS, 5 can be BLS. The only time BLS calls can be counted is during the spring. In the summertime, 15 additional ALS calls. And then in the fall, that is the capstone, so those are considered team leads. You'll need 25 in the fall. Those do not carry over, so you cannot do all 50 in the spring. Those are broken down sequentially by term. It must be met by the end of that term. We use FISDAP to schedule and track everything, so scheduling and tracking all of those shifts. That also sends reports to the sites. So whenever you schedule for a site in FISDAP, it sends a report to the clinical coordinator at that site to let them know that John Smith is coming on this date at this time. FISDAP also is what we use for accreditation to track all of those requirements. So a report can be generated so we can turn it into accreditation. It says, yep, here's proof they completed everything. This is a little quick reference guide from FISDAP on how to log all this stuff. So you can see in that right column is our program set minimums of what all you will need. And then in that middle column breaks down what those ages are or what the actual complaint is. So you can see there for cardiac dysrhythmia, right in the middle of the page, there's a couple things that can be considered for that. Whereas, in shock, if you log something as hypovolemia or shock, or an impression of a GI bleed, that counts towards the shock category. So you need to keep reference to this whenever you're logging stuff to make sure you're logging patients correctly. Within FISDAP, there's multiple options in the drop-down box of what complaints or impressions are, but this is where you need to be sure you're logging those appropriately by the complaint. And also in the skills, what counts for those, such as ventilations, intubations, that IV medication. So that IV medication can be a push, a drip, or a bolus, and just reference that chart. So if you want, take a minute, pause this to kind of look over this. Otherwise, this form is available for your reference. So scheduling, highlight again, for clinical, scheduling 72 hours prior, field 24 hours prior. All data for field and clinical, everything in the FISDAP from that shift must be entered 5 days from the end of the shift, or it does not count. The shift will lock and you cannot upload anything or change it. All the documentation you have filled out at the shifts must also be scanned and uploaded into that shift. There is a spot to upload attachments. All your documentation has to be there. FISDAP also has an app that you can do all this stuff in from your smart device. So tablet, phone, whatever it may be, you can use the app to input all the information, upload documents, everything you need. At the very beginning of your shift, you need to go over this form with your preceptor. This is in the field and the clinical setting. This lets that preceptor know exactly what you need, what your job is to be there. This is generally most helpful at the clinical setting, to where your preceptor may not even truly know what you're there for. So this gives an overview of what you need, what you're there for. So, if you're going in and you know that you need trauma patients, you can highlight all this stuff with the preceptor, say at the clinical setting, and say, please let me know if any good trauma patients come in. I like to be able to go and assess them and kind of be exposed to that patient. So it lets all of your preceptors know exactly what you need and how to fill out all the paperwork, what the whole plan is going to be for that day, basically why you're there and what you need to do and what you're allowed to do. So within that briefing, you will show them the skills authorization form. This highlights what you are allowed to do in that practicum setting. So it goes over all those A-list skills that you're allowed to do. Then you also show them the medication authorization form, which your instructors will sign off on. So basically everything that has an authorization signature or initials beside it are medications you are allowed to give. If you're not signed off on it, you are not allowed to give that medication. So this should be some enticement to get your drug quizzes completed. In the clinical side, this is a form you'll use to document your patient contacts. Basic demographic stuff, vital signs, assessments, what you did, what you saw, and some basic quick notes to remember for after the shift where you can go log all that information. This is the field documentation. This is just your patient care report. This needs filled out for each individual patient, filled out thoroughly like a real run sheet would be. Fill this out so you have all this information that needs put into FSDAP. Every option on here is an option to put something into FSDAP. Then a field evaluation goes with each PCR in the field. So for each patient contact, you get evaluated on each patient contact in the field only. You don't have to do one of these on each patient you come in contact with in ER because that's a much higher volume. So just a field evaluation on each patient in the field. During the capstone, when you become the team leader, you get evaluated the same way on each call, just with a different form. So do not use team leader until the final part of the program. Then at the end of your day for field and clinical, a shift evaluation. The preceptor goes over and can go over this with you, just how you did as a whole for their whole time with you. So some practicum pearls. All shifts must be submitted in FSDAP within 5 days after the end of that shift. All the documentation needs to be uploaded in that shift. PDF is preferred, but if you don't have access to doing that, which there's apps and everything to do that, make sure it's a good, clean picture. When it comes time to auditing, if the documentation is not good, we may not be able to count it. In the clinical, each patient assessment, log that as a new patient. You can only do 2 assessments on the same patient, and it's outside of ICU. So in the ED, if a patient comes in and you're doing multiple things to them, you're seeing them over and over and over, 2 at max on each patient. Remember, patients have multiple complaints, so be sure that you're logging both of those. If the patient is having chest pains and difficulty in breathing, and you log both of those, then you now have a chest pain assessment and a respiratory assessment. Be sure you just document appropriately. Only do skills and interventions that you have been approved to do via those authorization forms. Please, do not lie, do not forge documentation. Falsifying documentation will get you removed from the program. If there's any issues, you have all of our contact information. Contact us at any point. If you have bad preceptors, let us know. If anything arises while you're there, just shoot us an email, try to call our office phones, but definitely email is the easiest way to get hold of us.